My name is Liz Beckman. Welcome to this part of the celebration of CT at 50. In this section, we would like to share some videos about the patient experience of CT scanning in the 1970s and the medical usefulness of the technology in those early days. The first video we are going to see is Dr. Ron Evans, an eminent radiologist in America at the time, talking about one of the painful techniques often called an air study, a pneumoencephalogram that was frequently in use prior to CT.
CT scanning was introduced in 1972 at America's big annual convention of radiologists in Chicago. Since then, it's been the talking point of each convention.
I think the historical points about CT is that it ranks with the discovery of Röntgen, of the X-ray, and perhaps ranks with the discovery of the stethoscope. The other point I think is interesting is to envision where it fits in the history of medicine. The CT, it's difficult to place really when Godfrey Hounsfield made his invention because it was a series of research projects over a period of years, but it became clinically available in 1973, and the body machine became available in 1975, so 80 years after Röntgen's discovery. But if you think of hundreds of years of medical science, 80 years of radiology, and 3 or less years of CT, the impact that CT has had on medical care is very important.
The Mallinckrodt Institute, headed by Dr. Ron Evans.
Well, we did the first patient in the United States in October of 1975, which turned out to be a very exciting one. We felt from the beginning that the question of medical from surgical jaundice, the patient who has yellow jaundice who comes in, many of those have hepatitis. It's a disease of the liver itself, in which surgery doesn't help. That decision is very difficult to be made, and we felt CT could do it. The first patient we studied, it was an absolutely perfect study that I still use in talks about how good it was. And we made the decision that it was surgical jaundice, and correctly.
Okay, so there we have aorta, cava.
CT is steadily replacing the old methods of investigation. Invasive, often uncomfortable, they used to be the only way to look at organs like the pancreas, which aren't accessible to ordinary X-rays. To study the brain could involve undesirable procedures.
Okay, it's going to be a little pain in your head. Okay, the air is going into your ventricle system, into your brain. Okay, there will be some pain.
A pneumoencephalogram, which is an air study that people talk about, we used to do 2 or 3 of those a day. A lumbar puncture, or a needle is put into the spinal canal, and air is injected, and essentially let it bubble up into the head. And then the patient is put in all kinds of funny positions. Now that's the study that is at the very top of my list of studies that I wouldn't want done to myself. Now with CT, we're doing 1 of those a week. Sometimes we don't do any in a week. Now, to the 2 or 3 patients a day that we've saved that study, and especially if that patient was me, that test CT is worth one heck of a lot.
All the way down, your head will be close to the ground. We're going to take a picture in this position.
Here are 2 examples of pneumoencephalogram images, the one on the left, a view from the front, and the one on the right, a view from the side. The key areas are the ventricles, which are the darker black areas in the centre of each of these images, along the line between the 2 red arrows. The air has bubbled up into the ventricles in the brain, and is that which, as Ron Evans described in the previous video, the patients found very painful and distressing. The female patient in the video, who was smiling and didn't appear to be distressed, was an actress and had not actually had any air injected, so she was not in fact experiencing any pain or sickness. To her, it was more like a ride at a theme park. The type of ionic contrast agents available at that time could cause complications, reactions, and the examination to be very painful. It was not until the late 1970s, early 1980s, that non-ionic contrast was introduced. In the next video, we will hear from Dr. Forrest Claw, who was present when Godfrey Hounsfield presented CT scanning for the first time in the United States.
And by pure coincidence, I was at a meeting where Godfrey Hounsfield introduced CT scanning. He showed some of the images that were being produced, and then it became not only an interesting but an exciting thing, because up till that time we had to learn to diagnose ischemic strokes by learning all the small arteries throughout the brain, not just the major ones, but the small branches, and look for these little tiny arteries that were occluded by some embolus, or diagnose a hemorrhage by seeing the same type of vessels splayed or displaced, because we couldn't actually see areas of stroke or areas of hemorrhage on the angiograms that we were doing. And tumors were sometimes easier because a lot of times they had increased vascularity, so doing these angiograms, carotid angiograms, sometimes you'd see a blush, but if the tumor was not hypervascular, again, it was a difficult task. It was quite a challenge to make detailed diagnoses in neuroradiology in the brain. And so Hounsfield was showing these pictures of hemorrhages that you could see the blood as a different density than brain directly. You didn't even have to be very smart. You just look at the image, you say, there's a hemorrhage right there. And you could see how big it was, and its location, and what it was affecting, and what it was pushing on or compressing. And strokes were also visible, and tumors were just astonishingly visible. I mean, it was amazing. It didn't matter whether they were hypervascular or hypovascular or whatever. It was just an amazing phenomenon that I was witnessing.
So, prior to CT, there were two very unpleasant and painful imaging procedures for patients: angiography with ionic contrast, as on the left, and pneumoencephalography, or air study, as on the right. Forrest Claw has said that before CT, what he was looking for in angiograms, in order to be able to diagnose conditions like strokes, hemorrhages and tumours, was the arteries being shifted, misshapen or displaced into an unexpected position. The same diagnostic method was used in the pneumoencephalogram. Radiologists could see where the ventricles were, and from that they would infer what had moved the ventricles out of their normal position. CT, in comparison, gave a much easier and better diagnosis because it could show the abnormality directly and not by how it moved the arteries or ventricles. CT was far less traumatic for patients. Prior to CT, patients had frequently refused repeat procedures, which could have given life-saving diagnostic information, but they refused that because they were not able to tolerate the pain and side effects of the procedure again. Also, CT would show immediately whether surgery was urgent or not needed at all, as Dr. Ivan Mosley gives us some examples of in the next video.
In Britain, a specialist who scanned many accident victims is Dr. Ivan Mosley of London's National Hospital.
We have an example here of the most common condition which can occur after head injury, and this is a collection of blood between the brain and the skull itself, which presses on the brain and can indeed result in death. To show this before the advent of CT would have meant carrying out cerebral angiography with injections of rather toxic substances into the arteries leading to the brain. But here, very quickly and easily, within 10 minutes of the patient coming into hospital, we have the answer. This was an alcoholic who fell in the street, and you see here this large collection of blood, which is less dense than the brain, as we can see here, and it's displacing the ventricles away to this side and compressing the whole of the brain, expanding in this region. This is a life-threatening blood clot. This is a girl who, after a party, was beaten up by her boyfriend. And here on the left side is the area of contusion, which is seen as an area of low density, with little spots of blood within it. And on the next cut, you can see the ventricles once again displaced away from the side of the abnormality, and some blood here, which is seen to be less dense than the skull, which lies between the brain and the skull. Now, the scan here tells us, explains her condition, but it's clear that this is a condition which does not require surgical treatment, and so this is very important in the management of this patient. The third example that I've got here is a boy who was shot by his brother with an air gun, and the bullet entered the skull and passed more or less to the middle. And here is the point of entry of the bullet through the bone of the temporal region. And the track we see on the next cut. Here we can see the track through the brain, showing us exactly where it passed. We can see on these pictures that there is a star effect, lines radiating from the position of the bullet. This is because the bullet, which is very dense, it's made of lead, produces artifacts in the computer that it's as though the computer can't believe that the bullet is as dense as it really is. And so it attributes some of its density to the surrounding brain, producing this effect that looks rather like the moment of impact of the bullet upon the brain. And we were able to see from the position of this bullet on the scan that, once again, this was not in a life-threatening position, and it was decided that it would be better not to remove this bullet. We recently saw another patient who came into hospital complaining of pain in the head. It wasn't until after he'd been scanned that it became apparent that he too had a bullet in the head.
In the years between 1970 and 1972, there was a significant shift in the attitude of radiologists to the concept of CT, as Godfrey Hounsfield himself tells us, starting with the attitude that he found in 1970.
I went around the various hospitals, teaching hospitals, and I got no response whatsoever. They thought it was an extremely complicated and costly way of taking X-ray pictures, but and somehow telling them that this was about a whole orders of magnitude more accurate didn't seem to impress them much at all.
Hounsfield got a different reception when he went to America to talk about his discovery.
I showed these pictures, and they were very pleased with them, and afterwards a number of doctors persuaded me to go around hospitals showing the slides to the various hospitals. The result was that I hadn't brought enough money, and I had to keep down in a $5 a night place where a lot of students lived and people with haversacks and so on. And I did the trick, because when I came back, we had about 12 orders.
From what Godfrey said in that video clip, you might assume that radiologists in America, and in New York in particular, were much more switched on to the benefits and concept of CT than in the UK. But that is not correct, because what the radiologists in the UK saw in 1970 were only the two images that you can see here on the left. At the top, a rather crude scan of a formalin-fixed brain specimen, and below it, the abdomen of a piglet, which has had the centre of the abdomen removed and replaced by a water bowl with the letter E in it. Both of these were scanned on the very basic laboratory lathe bed scanner. These were the only images shown to UK radiologists in 1970. The purpose at that time was to discover if the concept was worth developing and a clinical prototype designing. At that stage, Hounsfield did not have the ability to scan living patients. The scans which he showed in New York were the 8 CT images of patients scanned at Atkinson Morley Hospital that you can see on the right. As you can see, they all had a clinical diagnosis done by Dr. James Ambrose. Forrest Claw and the others in the audience in New York could see immediately from the images tumours, cysts and hematomas. The diagnosis could be seen directly and not just inferred from arterial or ventricle displacement. These 8 images really show the breakthrough from CT, because although the images have lower spatial resolution than the angiograms or pneumoencephalograms, the fact that they have accurate density discrimination and by being a slice technique remove superimposition, they have provided better direct diagnosis. It's worth remembering that before Hounsfield's visit to New York in May 1972, he and Jamie Ambrose had shown these 8 images at the BIR Congress in London in April 1972 to an equally ecstatic radiology audience. At this stage, there was only one CT scanner in a clinical setting anywhere in the world. Over the next few years, head scanners were installed around the world, and whole body scanners developed and installed. By 1978, the medical community was beginning to understand the full benefits of CT, the benefits for the whole body, not just the head. The following videos show examples of the growing appreciation of the medical usefulness of CT scanners around the world, starting with Dr. Ron Evans again in America.
Dr. Ron Evans, chief of the Mallinckrodt Institute, believes many of the benefits are still to come.
I think that the major possible roads for the future with CT are several. One will certainly be in treatment planning, staging of patients with cancer, and their follow-up. Because the decision as to whether the treatment is surgery, or radiation therapy, or chemotherapy, various drugs, has to be made with an exact analysis of how far the cancer has spread. And this better image of the body by CT now allows us to have a new device to make that kind of decision. There are some other areas that will be a very important part of CT in the future. Heart disease, the application to the skeletal system, the application to the chest, the application to the extremities. We're just beginning to work on that. So that's the challenge for the physicians. Many institutions around the world will be making those evaluations. With new improvements in technology, with new improvements that we find as physicians, I think that we'll be able to demonstrate soon very many uses to nearly every patient with disease that CT has made possible. And the challenge to us as physicians, to the companies who are providing us the equipment, to make this a more important procedure, both in diagnosis and therapy, is our challenge.
Another example of the medical value of CT is given in the next video by Professor Ian Ishwood. Ian worked on the original EMI Mark I scanner installed in Manchester in 1973. This was one of the first 2 production machines installed after the original clinical prototype. Here he is explaining some of the benefits of the whole body CT.
Mr. Chadwick's had a problem.
At Manchester University in Britain, CT enables Professor Isherwood to show his students the anatomy of a live subject.
Some abnormalities which may be related to the pancreas, and we're going to investigate those this morning. Now, Mr. Chadwick's going to have a computer tomographic investigation on the EMI whole body scanner. Ordinary X-rays, no matter how sophisticated you make them, are going to be shadowgrams. Structures are superimposed one on the other. The new advance with computed tomography is to enable one to reconstruct the substance of organs and diseases affecting those organs by a computer method. And what it enables us to do is to look at the horizontal cross-section of the patient in this computed way by putting enough information in about the amount of X-rays going in and recording how much comes out. If you do that sufficiently often and in a sufficient number of times, one can compute the information
about the structure through which the X-rays have passed. And we can deduce information about the ability of those structures to absorb X-rays and then reconstruct them by computer methods. What we'd like to see is a horizontal cross-section of the body like this. And this is at a level where the pancreas would be expected to be. Now, on the CT scan here, we're just sectioning the kidneys. There's one kidney, and the black area in the middle is the hilum of the kidney, which is full of urine, full of water. So it appears black on here. And this organ stretched across it must be the pancreas. What computed tomography is enabling us to see, in addition, are the two lower density areas. These are two cysts in the head of the pancreas, which are expanding the pancreas and produced by blocking of the pancreatic ducts. And it's the sort of thing we might be looking for in Mr. Chadwick. Now, if you'd like to gather around this, this is a lead glass window, and you can just see Mr. Chadwick is in the hole in the middle of the polo mint there. The polo mint consists of an X-ray tube at one side and a series of X-ray detectors at the other. And those will move round him when we're taking the appropriate exposures, putting in known amounts of X-ray and computing what comes out. So we're literally taking an X-ray slice across him. Now here we're looking at the first section through Mr. Chadwick. Here's his initials on here. And here's his vertebral body. This is the liver and part of the spleen over here. And we're beginning to get hints here, can you see, of calcification, which we couldn't see on the plain films, in the tail of the pancreas. And if you look carefully there, there's a black ring in that area, which is very like that cyst we were looking at in the other patient, in the head of the pancreas.
Many patients wrote to Godfrey Hounsfield to thank him for inventing the CT scanner. Virtually none of those letters have survived. This one, which did survive, was on behalf of the husband of a patient who was very pleased that his wife had received a diagnosis as a result of her CT scan. He was so pleased that he went to EMI's head office in central London, presumably hoping that he could actually meet Godfrey and thank him face to face. But Godfrey Hounsfield worked about 15 miles away in West London. And so Rachel Nelson, who worked in public relations in EMI's head office, saw the gentleman and sent Godfrey Hounsfield this letter on his behalf. This shows the great appreciation of patients for Godfrey Hounsfield's invention of the CT scan, and is a very nice way of ending this section. Thank you for watching this section on the patient experience and medical usefulness of early CT scanning as part of the celebration of CT at 50.